This is Ocular Disease and Refraction Spotlight for diabetes. Diabetes has a prevalence in the United States of about 34.2 million people, or about 10% of the population. This is according to the American Diabetes Association. Nearly 1.6 million Americans have type 1 diabetes, including 187,000 children and adolescents. Of those 34 million, approximately 26.8 million have been diagnosed and 7.3 million are currently undiagnosed in the country. Prevalence in the senior population is significantly higher, with a prevalence of about 25 to 26% of the population over the age of 65 having diabetes. And this accounts to about 1.5 million new cases diagnosed every year. Diabetes ultimately can have an effect on people's refractive error. And that's primarily done through changing the lens structure to becoming more curved and swelling. If we think about our ocular biology, the lens has a circulation system where it brings in nutrients and water and expels them around the lens. And it does this through a sodium-potassium pumps. Here's an example further of those sodium-potassium ATPase pumps and calcium pumps. However, it does also allow for diffusion of actual glucose through that membrane. And that's facilitated diffusion of glucose into the lens, and the lens needs glucose as a power process, just like any cell. Ultimately, though, this glucose can affect the circulation of the net solutes and generate fluid flow. How it does this is, as we increase the amount of glucose in the anterior chamber and ultimately the lens, aldose reductase changes this to sorbitol, and eventually it will be changed to fructose. Unfortunately, though, as sorbitol increases within the lens, it cannot pass through the plasma membrane. So sorbitol, unlike glucose, which can diffuse, increases in concentration relative to the rest of the aqueous humor. This ultimately leads to an osmotic pressure increase and uptake of water into the lens. This causes the lens to swell while scattering light, but it also changes the structure of the lens. Here's an example of a study looking at the change in lens thickness for diabetics. If we look at our controls versus diabetics with no retinopathy, diabetics with mild retinopathy, and diabetics with proliferative retinopathy, as the severity of the diabetes increases, the thickness of the lens also increases. And this can be measured using ultrasound or OCT. Now you might ask your question, what's the difference between mild retinopathy and proliferative retinopathy? That's an excellent question, which is for more ocular disease courses. This course is focused on refractive changes due to disease. In the example on the left, we have a case of mild retinopathy, which is dependent upon the number of hemorrhages, essentially, and exudates in the eye. The example on the right of proliferative retinopathy has more exudates, neovascularization, as well as exudates very close to the fovea. And this is what makes it proliferative. Ultimately, though, these changes in the lens are not due to short-term fluctuations in sugar. Here's a study where they actually increased the blood sugar to 300 or so. And what you see is there's a very little change in refractive error over the short term in the lens thickness. That means that this elevated blood sugar, needs a chronic presence to actually cause changes in refractive error. Now, we use hemoglobin A1C to diagnose diabetes. What hemoglobin A1C tests are is it tells the average level of blood sugar over the past 2 to 3 months, or more of a chronic measure of how much sugar is in the blood. The hemoglobin A1C is a measure of how much glucose or sugar is glycosylated or attached to hemoglobin. Because our red blood cells are replaced every 2 to 3 months, that's why this is a measurement over time, over that period of time, is that as the red blood cells die, they go away. What the hemoglobin A1C is a measure of that blood sugar, what percentage of that blood sugar has glucose glycosylated to it or stuck to it. Now, ultimately, on a typical person, we're actually looking at between 4 to 6% of your blood sugar on any given day will be glycosylated. Now, if you have higher than that, above 6, you're at risk for diabetes. And in fact, that's how we diagnose diabetes oftentimes, is 2 readings above 6.5 on an A1C scale are diagnostic for diabetes. And these ultimately correspond to average blood sugars. At an A1C of 4%, approximately the blood sugar level is approximately 68%. As we reach 8%, that blood sugar reaches 183 milligrams per deciliter. Now, ultimately, this level, the higher level of A1C, can cause these myopic shifts. Patients above 8% are far more likely to see an increase in their myopia or a myopic shift compared to lower amounts of sugar. It's also the length of time matters for actually seeing myopic shifts. If we see here and look at the length of time, the people who've been diagnosed relatively shorter are more likely to have myopic shifts. The ones that have had diabetes longer have less shifts. And this is due to chronic damage, and those people in the older group probably not changing very much anymore. They also have more likely to have cataracts and other things going on that prevent that lens from changing much anymore. Either way, though, if you have an increased hemoglobin A1C, you have a higher risk for a myopic shift over the time period. In fact, if you're over 8.8%, you have a 50% chance of having a myopic shift compared to the other group. And this has been studied in multiple different studies. This is just a short list where we see myopic shifts as the blood sugar goes up, and we also see conversely hyperopic shifts as the sugar is controlled and the sugar goes down. And that's something to keep in mind. Again, on average, myopic shifts with high blood sugar, and as we control our sugar, there's a corresponding hyperopic shift after getting sugar under control. Here's an example of one patient's shift. They initially had a myopic shift, and as they were put under blood sugar control, they had a rapid shift of hyperopia, up to 4 diopters in this case. And ultimately, this took time. It reached the pinnacle at about 1 month, but it ultimately took about 3 months for stabilization of the person's refractive error. If the patient gets the blood sugar under control, then we need to consider with our patients how long it might take them to stabilize. That might be 1 to 3 months, given the person's desire to actually control their blood sugar. So we need to consider some special issues with our diabetic patients. One of the things we should really consider is never prescribe without understanding the patient's visual, hobby, and career needs, and how this new prescription might affect them. With diabetics, we have a couple questions there. Do we need to prescribe something for them to be functional for the next few months? If they had that 4 diopter shift, they might need to have something prescribed. And that would be if it's affecting their jobs and they can't do it, or they can't really live their life normally, you may need to prescribe this for them. Again, if they have a large change, a new ARCS might be needed. If it's a small change, though, maybe they can wait and get the new glasses after the blood sugar is under control. Large changes in the prescription in the ear, you should also consider ocular disease such as cataracts and diabetes. If this person had a large shift with diabetes, perhaps they also have retinopathy. Perhaps they have macular edema, which is far more pressing than worrying about their glasses prescription today. So these are all things to take into context as you're making decisions clinically. Never prescribe without understanding the patient's visual hobby needs, as we just discussed. Also, you need to remind all patients with RX changes they may need to adapt to these new glasses. There's going to be some major adaptation issues with these people because their prescription is changing actively over the next couple months. But the most important thing, if you're going to prescribe to a diabetic who's had a change in the refractive error, is set expectations for any prescription change. Any new ARCs given may change in a few months, and the patient needs to know that. And the reason why they need to know that is the patient oftentimes will be responsible for any costs of these changes as their blood sugar gets under control. Thank you.